I still remember Mrs. Johnson's face when she came back to the hospital, just 12 days after we'd discharged her. The confusion in her eyes, the fear in her husband's voice. "But doctor, we did everything you said," and they had. They'd followed every instruction we gave them. But what we failed to do was prepare them for what I now call the silent killer. The dangerous gap between hospital care and home recovery that claims thousands of lives every year. I'm Dr. Sarah Mitchell, and after 27 years as a cardiologist, I've watched too many patients return to the hospital within weeks of discharge. Some never make it back at all. What I'm about to share with you today isn't taught in medical school. It's what I've learned from thousands of patients who have struggled in that critical transition from hospital to home. And it might just save your life or the life of someone you love. Let me start with some numbers that should alarm you. Nearly 1 in 5 Medicare patients returns to the hospital within 30 days of discharge. For heart failure patients specifically, that number jumps to nearly 25%. Think about that. 1 in 4 heart patients will find themselves back in a hospital bed within a month. But here's what's truly frightening: each readmission increases mortality risk by approximately 20%. That means your chances of survival actually decrease with each hospital return. We're not just talking about inconvenience or additional medical bills. We're talking about life and deaths. When I first saw these statistics early in my career, I assumed these were patients who weren't following medical advice. I was wrong. Many of these readmissions happen to people who are genuinely trying to do everything right. People like Mrs. Johnson, who took every medication exactly as prescribed. Or Mr. Ramirez, who scheduled and kept every follow-up appointment. So what's really happening here? Why are so many patients coming back? I've come to call the first 2 weeks after hospital discharge the danger zone. It's when patients are most vulnerable, yet often least supported. Think about it: in the hospital, you have round-the-clock monitoring. Nurses check your vitals every few hours. Doctors review your case daily. Medications are administered precisely on schedule. Then suddenly you're home. The monitors are gone. The nursing staff is gone. The structured medication schedule is now entirely in your hands. And your body is still healing, still vulnerable. Lies? Remember Tom, a 68-year-old former construction worker who'd had a moderate heart attack. In the hospital, he was stable, improving daily. We discharged him on a Thursday with prescriptions, follow-up appointments, and a list of warning signs. By Sunday night, his wife was calling 911. Tom was back in the ER with heart failure. What happened? Multiple factors created a perfect storm. First, Tom didn't fill all his prescriptions immediately. The pharmacy was closed when they got home Thursday, and they waited until Friday afternoon. He missed several doses of a critical medication. Second, Tom didn't understand that the mild swelling in his ankles was an early warning sign. By the time he had trouble breathing, a late-stage symptom, his condition had already deteriorated significantly. Tom's story isn't unusual. It's alarmingly common. And it illustrates why this transition period is so dangerous. The hospital-to-home gap isn't just inconvenient, it's potentially deadly. Let's talk about one of the biggest readmission triggers: medication errors. When patients leave the hospital, they often face what I call the medication maze, a confusing new regimen that can be overwhelming to manage. Consider this: the average heart patient is discharged with 7 to 12 different medications. Some need to be taken with food, others on an empty stomach. Some twice daily, others 3 times. Some can't be taken together. It's complicated even for healthcare professionals to keep straight. Maria, one of my patients in her early 70s, came home with 9 different prescriptions after valve replacement surgery. Before her hospitalization, she was only taking 2 medications. Suddenly, she had this complex schedule to follow. Her daughter found her one morning, confused and disoriented. Maria had accidentally doubled up on her blood pressure medication and missed her diuretic entirely. What makes this particularly challenging is that medication instructions are often given during discharge, when patients are anxious to leave, tired from their hospital stay, and possibly still affected by medications. It's literally the worst possible time for critical education. And here's something few doctors will admit: our discharge instructions are often terrible. They're written in medical jargon, printed in tiny font, and rarely organized in a way that makes sense to non-medical people. Yet we expect patients to follow them perfectly, with little to no support. The consequences: missed doses, incorrect doses, dangerous drug interactions, all leading to complications that send patients right back to the hospital. Or worse. Another major factor in readmissions is what I call symptom confusion. Patients simply don't know which post-discharge symptoms are normal and which are emergencies. Is that chest discomfort just surgical healing or another heart attack? Is shortness of breath when climbing stairs normal recovery or worsening heart failure? Is dizziness a side effect of medication or something more serious? These aren't simple questions, even for medical professionals. Yet we often send patients home with vague instructions like "call if you experience unusual symptoms." What exactly is unusual for someone who's just had heart surgery or a cardiac event? I had a patient, Robert, who experienced increasing fatigue for days after discharge. He assumed it was normal recovery. By the time he called our office, his heart was functioning at less than 25% capacity. Had he recognized this symptom earlier, we could have adjusted his medications and prevented his emergency readmission. The truth is, most patients err on one of two sides. They either panic about every twinge and rush to the ER unnecessarily, or they dismiss serious warning signs until it's nearly too late. Neither extreme serves them well. And here's where I need to pause and acknowledge something important. This isn't patients' fault. It's a system failure. We in the medical community have not created effective transition processes. We haven't adequately prepared patients for this critical period. And people are suffering, even dying, as a result. Now let's talk about what I call the follow-up fallacy. The mistaken belief that scheduling a follow-up appointment automatically ensures proper care continuation. Standard practice is to schedule patients for follow-up 2 to 4 weeks after discharge. But remember what I said earlier about the first 2 weeks being the danger zone. That means many patients won't even see their doctor until after the highest risk period has passed. Even when earlier appointments are scheduled, there are numerous barriers. Transportation issues. Confusion about which doctor to see first. Insurance authorization delays. Appointment availabilities. Many patients, especially seniors, face real challenges just getting to these critical appointments. James, an 81-year-old patient of mine, missed his 1-week follow-up because his daughter, who was his only transportation, had a family emergency. By the time he rescheduled, he was already experiencing complications that required readmission. But here's something even more concerning. Even when patients do make their follow-up appointments, crucial information is often missing. Hospital discharge summaries frequently don't reach primary care doctors in time. Test results get lost in the system. Medication changes aren't communicated. I've had patients arrive for follow-up where I had no idea what happened during their hospitalization. No discharge summary. No test results. Just a patient in front of me saying they were in the hospital last week. This communication breakdown puts patients at serious risk. Another critical factor I've observed is what I call the lifestyle limbo. That period when patients are unsure how to adapt their daily habits after a cardiac event. Hospital discharge instructions typically include vague lifestyle guidelines. Maintain a heart-healthy diet, get regular exercise, reduce stress, but what exactly does this mean in practical terms? Can you climb stairs? How many? Is walking to the mailbox enough exercise or too much? Which foods are truly heart-healthy and which should you avoid? How do you reduce stress when you're worried about your heart condition? I had a patient, Alina, who was so afraid of overexerting herself after a heart attack that she barely moved from her recliner for 2 weeks. The result? Muscle deconditioning, fluid retention, and depression, all contributing to her readmission. On the flip side, I've had patients like George, who decided his heart attack wasn't that bad, and resumed his heavy yard work just days after discharge, landing him back in the cardiac unit with complications. The truth is, recovery isn't one size fits all. Personalized guidance is essential. But our healthcare system rarely provides this level of individualized support during the transition period. This brings me to another crucial factor, what I call the support system shortage. Many patients, particularly older adults, lack adequate support at home during recovery. The healthcare system increasingly relies on family caregivers to provide complex care that was once delivered by medical professionals. These family members are suddenly expected to manage medications, monitor symptoms, change dressings, and make critical health decisions, often with minimal training or support. I remember Sarah, whose husband David was discharged after bypass surgery. Sarah was 72 herself, with arthritis that made it difficult to help David move safely. She was overwhelmed by the responsibility of his care, but didn't want to admit she was struggling. When David fell trying to get to the bathroom without disturbing her, both ended up in the hospital, he with reopened surgical wounds, she with a broken wrist. Even in the best circumstances, with willing and capable family members, the burden of care can be overwhelming. And many patients don't have this support at all. They return to empty homes, expected to manage their own recovery in isolation. Our healthcare system has created an impossible situation. We've shortened hospital stays, increased the complexity of at-home care, and failed to provide adequate support services to bridge the gap. Let's talk about something that rarely makes it into discharge plans: the emotional impact of heart events. I call this the emotional aftermath. A heart attack or cardiac surgery isn't just a physical event. It's psychologically traumatic. Patients face their mortality, often for the first time. They grapple with fear, anxiety, depression, and a profound sense of vulnerability. These emotional responses aren't just uncomfortable, they directly impact physical recovery. Anxiety increases heart rate and blood pressure. Depression reduces medication adherence. Fear can prevent necessary physical activity. I remember Michael, a 59-year-old executive who'd never experienced significant health problems before his heart attack. He returned to the hospital 3 weeks after discharge with symptoms mimicking another heart attack. After extensive testing, we determined he was experiencing panic attacks triggered by the fear of having another cardiac event. Yet our discharge protocols rarely address these psychological aspects of recovery. We send patients home with medications for their hearts, but no support for their minds. This oversight contributes significantly to readmissions. We need to acknowledge another reality that impacts recovery: the financial burden of heart disease. I call this the financial factor. Heart conditions are expensive. Even with insurance, patients face significant out-of-pocket costs: copays, deductibles, medications, equipment, and often lost income during recovery. These financial pressures create impossible choices. Should I fill all my prescriptions or pay my electric bill? Should I keep my follow-up appointment or save the copay for groceries? I had a patient, William, who started cutting his heart medication in half to make it last longer because he couldn't afford the refill. The result was predictable and devastating: readmission with serious complications. For many patients, especially those on fixed incomes, The financial strain of heart disease management contributes directly to non-adherence and subsequent readmissions. This isn't about patients being irresponsible. It's about a healthcare system that places financial barriers between patients and necessary care. So far, I've painted a pretty grim picture. But I don't want to leave you feeling hopeless. There are solutions to this readmission crisis, what I call the bridge over the danger zone. First, we need comprehensive discharge planning that starts the moment a patient enters the hospital, not hours before they leave. This planning should include medication reconciliation, clear symptom guidance, and individualized recovery instructions. Second, we need transitional care programs that provide support during those critical first 2 weeks. This might include home visits by nurses, telehealth check-ins, or structured phone follow-ups. Implemented a cardiac bridge program in my practice 5 years ago. Every heart patient receives a follow-up call within 48 hours of discharge, a nurse visit within the first week, and a physician appointment within 2 weeks. We've reduced our readmission rates by 62%. Third, we need better medication management systems. This includes simplified medication schedules, clear instructions with visual aids, and technology solutions like reminder apps or prepackaged medication systems. Fourth, we need to address the emotional and psychological aspects of recovery. This means screening for anxiety and depression, providing mental health resources, and incorporating stress management into recovery plans. Fifth, we need to strengthen support systems for patients and caregivers. This includes better training for family caregivers, connection to community resources, and expanded home health services. And finally, we need to acknowledge that preventing readmissions requires investment. It means longer hospital stays when necessary, more intensive follow-up care, and better coordination between hospital and community providers. The good news is that these investments pay off, both in lives saved and healthcare costs reduced. When we implemented our bridge program, we not only reduced readmissions, but also lowered overall care costs by 28%. I started today by telling you about Mrs. Johnson, who returned to the hospital despite following all our instructions. What I didn't tell you was what happened next. After her readmission, we enrolled her in our cardiac bridge program. She received the support she needed during that critical transition period. Today, 5 years later, she's thriving. She hasn't been readmitted once. Her story represents both the challenge and the hope in addressing the hospital readmission crisis. The danger is real. That gap between hospital and home recovery truly is a silent killer, but it doesn't have to be. If you or someone you love is facing a hospital discharge after a cardiac event, here's what you need to do. Ask for a detailed discharge plan that includes specific symptom guidance, what's normal and what's concerning. Request a medication management plan that's clear and simplified as much as possible. Ensure follow-up care is scheduled within the first week, not just the standard 2-4 weeks. Connect with support resources before leaving the hospital, whether that's home health services, caregiver training, or community programs. And perhaps most importantly, advocate for yourself or your loved one. Ask questions. Express concerns. Request additional support if you're feeling overwhelmed. The transition from hospital to home doesn't have to be a danger zone. With the right preparation, support, and follow-up care, it can instead be the beginning of a successful recovery journey. Thank you for joining me today. I hope this information helps you navigate the critical hospital-to-home transition safely. Your heart health journey doesn't end at discharge. In many ways, that's where it truly begins. And with the right knowledge and support, you can make that journey successfully. This is Dr. Sarah Mitchell reminding you that when it comes to heart health, what happens after the hospital might be even more important than what happens during your stay. Take care of your heart, and I'll see you next time.